So first we'll see the overview. With the overview, we'll learn about the corneal anatomy first and how it heals, followed by the corneal
You're not able to
clinical
see.
signs.
Excuse me, we are not able to see the presentation.
Okay, one second.
It's visible.
It is clearly
Yes.
Is it now, sir?
Yeah, it's visible.
It's
Visible, doctor.
visible.
clear, madam.
Yeah, you can proceed.
Okay. So then is the clinical signs followed by the diagnosis and how to evaluate the ulcers, what are the types of ulcers, and most importantly, when to refer. So as far as corneal anatomy is concerned, so there are three basic layers. One is corneal epithelium, stroma, and endothelium. There's a very small membrane in between the stroma and endothelium that is called as a Descemet's membrane. So epithelium is nothing but as usual, like other normal epithelial cells. Stroma is composed of collagen sheets, which are composed in such a special manner that it gives the cornea glass-like appearance. Wound healing is very, very important when it comes to the cornea because not all the layers in the cornea heal in the same way. So as far as epithelium is concerned, it heals by a normal mitosis. That means the normal epithelial cell will be replaced by the same sort of epithelial cell. And this healing starts immincing by time of 72 hours. And as we know that the epithelium is replaced by the similar sort of cell, so in such kind of ulcers, we will see minimal scarring. When it comes to the stroma in the stromal ulcers, there'll be sliding epithelial cells also, as well as proliferation of keratocytes and fibroblasts. But what happens in the stromal healing is the stroma is not like replaced by the normal stromal tissues. Most of the time, there are the fibrocytes which replace the normal stromal cells. That leads to a scar formation on the cornea. And sometimes there are the cases where stromal loss cannot be refilled. So in such cases, there'll be a depression on the cornea. In such depressions, what happens is epithelium will be formed, but there'll be still loss of stromal tissues. So we will see a depression on the cornea, but there won't be any stain retention. And when endothelium comes, endothelium is the layer of the cornea which never ever regenerates. So whatever cells we are born with, we are having that right now. So when there is a loss of endothelial cells, so what happens is the nearby cells swell up and they enlarge and try to fill up the lost space. So in this sort of process, some of the endothelial cells go for death also, and that leads to endothelium degeneration. Usually in all the canines, felines, including humans also, it is like endothelium doesn't regenerate. Only I think rabbits are the only species where they have the capacity to regenerate their endothelium. So once endothelial cell is lost, it's lost. When corneal healing is concerned, there is a role of various enzymes also, and most common enzymes among them are proteases. Proteases are produced by epithelial cells, keratocytes, inflammatory cells, and as well as a precorneal tear film. So proteases have a huge role in corneal healing as they help in degradation, regeneration, remodeling. So what happens is when there is a corneal ulcer, there'll be some bacteria also around that. So bacteria also produce proteases or a lot of proteolytic enzymes. So when there is an imbalance in the proteases, there'll be a lot of degeneration or collagenolytic activity on the cornea. So if it is not controlled timely, it leads to melting ulcers also. So when we have a corneal ulcer, what we are supposed to see when the pet comes to us, first sign will be or the complaint will be like pet is squinting the eye. So pet won't be comfortable. So there'll be a lot of pain. Cornea is a very sensitive layer. So most of the corneal ulcers are very, very painful. So first sign that a pet will show is squinting. That means like it won't open the eye properly. There'll be a lot of blinking or sometimes sensitivity to the light. Some pets have sensitivity to the light to such an extent that there'll be a prolapse of third eyelid. And further, the signs, if we go deeper and deeper and see the eye, there'll be a redness around the eye. So conjunctiva will be really injected. There'll be redness, lot of watery discharge from the eye. And when there is a break of epithelium, usually cornea is a avascular structure. So when there is any break in the corneal epithelium, stroma tends to imbibe the water from the adjacent spaces, whether it's a aqueous or whether it's a tear. So due to that, there'll be a corneal edema. There'll be increased thickness of the cornea, as well as it'll give a bluish tinge on the cornea. And sometime in some of the cases when there is an infected ulcer, it goes so bad that there'll be a pupil will be myotic, and there'll be little haziness even in the aqueous humor. So that is called as a reflux uveitis, which has happened in response to infected ulcer on the eye. And of course, when there is a deep ulcer or there is a like perforation or something, there'll be a change in the curvature. Sometime we will see a clear depression in case of a corneal ulcers on the corneal surface, or sometime if there's a perforation, there'll be inside tissue bulging out that leads to change in the curvature of the cornea. So next is diagnosis. So usually what I feel is cornea speaks to you. So first is, rather than jumping into any conclusion straight away or going for the treatment, first we have to assess the cause, why cornea has ulcerated. So usually it can be eyelid abnormality, foreign bodies, dry eye, and some pets, like most of the brachycephalic breeds which are over-presented with the corneal ulcers, they have a habit of rubbing their face because of lot of allergic issues on the facial region, so that also make them prone for the ulcers. And usually whenever a case comes to us, it comes like a squinting eye or very red eye and all. So that red eye can be anything, it is not always a ulcer, it can be normal conjunctivitis also, ulcer also, uveitis, glaucoma, or even a dry eye. Or in case of allergic issues also, there'll be like redness in the eye. So all red eyes are not like the signs of like ulcer. So there are different conditions which can be presented similarly, so we have to differentiate and go for the treatment accordingly. So usually ideal is whenever you are seeing a red eye or something like that and you are not sure, run 3 tests blindly. One is STT, that is some Schirmer tear test. Second is this fluorescent dye test, and third is the intraocular pressure. Though there's a constraint that intraocular pressure cannot be checked at all the wet places, but STT and fluorescent dye testing is pretty simple and we can do easily at all the places. So causes of corneal ulcers, if we see like in normal thing is like there can be trauma, like pet has accidentally scratched the eye, there are foreign bodies or some chemical went into the eye, especially the harsh shampoos. Sometimes it can be eyelid issues, like we see most of the eyelid issues with the brachycephalic breeds. Sometimes it is entropion or medial entropion, trichiasis, or there is ectopic cilia, which creates constant irritation and leads to the ulcers. Sometimes even in the dry eye cases also, there'll be more dryness on the center part of the cornea that will lead to corneal exposure keratitis, further leading to ulcer. Sometimes neurological factors that are quite rare. It is not very common that pet will be presented with a neurological thing that will lead to an ulcer. Usually, if it is, we can see the conditions where there is trigeminal nerve paralysis or facial nerve paralysis, the cases where they cannot blink properly. So when they are not able to blink properly, that time also there'll be dryness on the cornea and more exposure that will lead to ulcers. Usually, eye infections or even endocrine diseases also make them prone for the eye ulcers. And as we all know that brachycephalic breeds like pugs, shih tzus, bulldogs are well known for inherently predisposition for the corneal ulcers. So when we are suspecting, the first diagnostic test and the easiest most is fluorescent dye. So fluorescent dye is nothing but it is a dye which is a hydrophilic in nature and it has affinity towards the stromal cells. So in ulcer, whenever there is a loss of epithelium and all, so whenever we put a dye on that, so it will stick to that exposed stromal part. And in a cobalt blue filter, we can see that fluorescent stain uptake on that particular part. So usually there are rose Bengal dyes or there are different, but most commonly and most easily available is fluorescent, and it is most convenient also as it sticks particularly to the stroma. So we cannot like get us confused with the dead cells or so and so. And how to use it? It is basically comes as a in a strip form. So usually without touching, you have to open the strip, just place it near the eye and put a drop of saline over it. So this will smear all of the cornea and just test it in a cobalt blue filter. Usually, as like in my personal thing, if I know that this is an ulcer without like, so I, in those cases where I know that this is an ulcer only, so in those cases, I try to avoid like using fluorescent stain. Personally, if it is well evident that this is a ulcer and all, usually fluorescent dye, why I want to like not use in such cases is because most of the time it can be in the deep ulcers little epitheliotoxic also. So in the cases where I know that this is a corneal ulcer, it is pretty deep and well evident, then I would like to avoid doing the dye test. But if we are beginner and all, there is no harm in confirming with the dye. So using dye once doesn't like harm a lot rather than having a misdiagnosis. And second thing is, it's like after using the dye, flush the eye well. So clean it well. Even tell the owner also that this marks or the dye stain will persist for some time and afterwards it will be washed away with the natural tears. So when I'm seeing the ulcer, I assess for the location also because location at what part ulcer is present, it also tells a lot about why the ulcer is there. So usually if we are seeing an ulcer on the cranial or dorsal segment near the upper eyelid, always check for ectopic cilia, trichiasis or dystichia. So ectopic cilia is nothing but an eyelash present at abnormal place, or it is like misdirected toward the cornea. And same as with the trichiasis, is a misdirected hair towards the cornea. And this trichia is nothing but there are two lashes coming out from a same spot. So sometimes they are rotated inwardly towards the cornea and they keep on irritating the cornea continuously, leading to ulcer. If we are getting an ulcer on the lateral aspect, lower lateral aspect, we should check for the entropion because at this place, pets are likely to get entropion and the hair, the periocular hair keep on rubbing around the cornea and irritating it, leading to the ulcer. And usually in case of foreign bodies, most of the ulcers are present on the medial aspect, down medial aspect, because it's like most of the foreign bodies tend to lodge in the third eyelid. So when they are lodging in the third eyelid, they keep on rubbing and create the linear lacerations on that area. So if you are getting ulcer on the medial aspect, please check the third eyelid also once whether there is something lodged over there causing the ulcer or irritation. And most of the ulcers, central ulcers or axial ulcers, are as a result of trauma, like a scratch on the eye or any trauma, or even the dry eye. Mostly in dry eye cases, what happens is the cornea gets desiccated very fast. And the central cornea is the corneal part which is exposed for the most time. So due to the dryness over that part, this area becomes prone for the ulceration. So how do we evaluate a corneal ulcer? First, look at the size, like what is the like how much approximate size is there and how much percentage of the cornea it's covering. Usually, size will help you to see the progression as when corneal ulcers start healing, it will start contracting. So we can make out like last time it was around 5 mm, now it's 3 mm, so we are on the good go. So with that, it will help us to see like whether our treatment is working or not. Second is a location. If I have a ulcer which is at a limbal area, or it is central or towards the temporal side or nasal side. See, if my ulcer is towards the limbus and all, then I won't be that much worried, because sooner or later the blood vessels from the conjunctiva will come there and they'll initiate the healing faster. And next comes presence of the blood vessels. Blood vessels are very, very important when it comes to the corneal healing, because cornea as such is a avascular structure. So from the blood vessels from the adjacent conjunctiva or the nearby region have to come there to provide the nutrition and all the healing factors for the ulcer to heal fast. Usually we see vascularization in normal ulcers within a week's time. And when vascularization starts, usually vessels move by 1 to 2 mm per day. So roughly with this we can draw a timeline also, like in what time we should expect our ulcer to heal. And next is depth. So whether it's a superficial ulcer or a desmetocele, obviously if it is a superficial ulcer, we will start seeing healing by 72 hours. But same time when it is a desmetocele or a stromal ulcer or deep ulcer, we have to expect our timeline somewhere between 2 to 3 weeks. And please look for Malaysia also. Malaysia is nothing but a melting of the ulcer. If you feel that the cornea is really milky white and squishy in nature, it is not having that much integrity and it's very softened, then we have to start the treatment like an emergency treatment. And last but not the least, look for the corneal infiltrates or deposits. Like sometimes there'll be calcium deposits and all. These deposits make the cornea more prone for ulceration. So next is what are the types of ulcers? So we have superficial, stromal, indolent, desmetocele, and perforation. So usually the type of treatment also varies with the type of ulcers. So when it comes to the superficial ulcers, they are easiest to tackle. So usually you'll see whenever you are getting a superficial ulcer, the signs will be same, only that pet will be blinking the eye a lot, there'll be watery discharge or discomfort in the eye and all. And when we do a dye test, there'll be crisp edges of the dye. It won't be like smudged up appearance. And it is most of the time like not, the corneal curvature doesn't change much. There you won't get much of the depression on the cornea. So usually these ulcers, these are uncomplicated and healing starts as soon as in 72 hours. So they usually, we should expect them to heal within 2 to 6 days. And if they are not healing, please reevaluate, because reevaluate whether we are missing something or they are superficial or they are just looking like they are superficial. So as far as the treatment is concerned, I would go for the broad spectrum antibiotic just to avoid the secondary bacterial infection which will complicate the ulcer. Atropine, if the pet is having reflux uveitis, like his pupil is small or you feel pet is in real pain and all, that time we can use atropine. But in these cases, it is optional. And e-collar is must. So as far as his treatment is concerned, I would like to always go for the broad spectrum antibiotics, and that neopolybac is like the choice of antibiotic along with chloramphenicol. We have to use it 2 to 3 times a day, and one drop is sufficient at a time. If we are putting 2 drops or 3 drops at a time, it is of no much use. It's not like if you are using more, it will act more. Dog's cornea or dog's eye is designed in such a way that it can only contain 1 drop. So 1 drop at a time is enough. And if you feel that your pet moved and you are not sure whether that drop fell on the cornea or not, so please wait for 5 minutes and instill the another drop. And unfortunately, as we see like Indian farmer scenario, we hardly have any of the eye drops which have these two mentioned antibiotics. Usually neopolybac. So far I have not come across with any of the veterinary formulation which they have this antibiotic. Even chloramphenicol is also the same. Like there are no animal like proper veterinary products with this. Usually what I'm using is right now is the human eye drops only. But the thing is, it is Antibiotic is not the thing which is healing the ulcer. The corneal ulcer will heal itself. It is not healing, it is just to take care of the secondary infection. So don't go for the antibiotic just as a lone treatment. It is like it is just to avoid the infection. Cornea will heal itself. And second thing is e-collar is must no matter what you do, how many medications you give, until unless pet stops irritating that ulcer or that site, it won't heal. So e-collar is must. If you are not knowing what is wrong with the eye and all, you get a call that there is something wrong and all, please, I will always advise everyone to please tell the clients like at least put the e-collar first. Even eye drop is not as much as necessary as putting the e-collar. And how do we recheck it? So we, for the brachycephalics, I would like to recheck that ulcer every 1 to 2 days till the time I am satisfied that this is shrinking and the size is reducing and the pet is more comfortable. As the ulcers start healing, how would you know is like you will tell the client that his discomfort will start getting down, even the blinking will become better, and the watery discharge also will reduce. In non-brachycephalic breeds, I'm little like laid back, so I'll see that ulcer like I'll recheck that ulcer in 3 to 5 days. So next is SCEDs, that is spontaneous chronic corneal epithelial defects, or also known as indolent ulcers. So the name indolent itself says that it is a lazy ulcer, so it won't go easily no matter what you do. So it will take its own time. And this is always superficial, superficial, superficial. So never ever treat it as a deep ulcer. It will always come a superficial ulcer. So if any ulcer you have that is persisting for more than 1 week, so please think of whether it's an indolent ulcer or a SCED. And how do we find it out? It will be very superficial. There'll be corneal curvature will be more or less same. And when you see the ulcer edges, there'll be loose epithelial edges. So there'll be epithelial lip that will be loose. So if you see it in the image also, in both the images, there's in the sides, edges of the ulcers are very loose. And when we do a dye also, so there'll be a halo formation. So in this type of ulcer, there is minimal to reflux uveitis. We don't get reflux uveitis as commonly in these sort of ulcers, but these are pretty much headache to tackle with. And usually they are not going to get better with the normal eye drops and e-collar. So when it comes to the SCEDS treatment, first is like we have to get rid of that loose epithelial tissue. Basically, that tissue is the epithelium is healing, but it is not attaching properly on the stroma. That's why that ulcer doesn't heal. So we have to create an environment good enough that epithelial cells start attaching to the stroma. So what we can all do is like all the vets can do at their clinics or thing is first is CTA debridement. Of course, you have to start with the broad spectrum antibiotic, eye drop, or if pain is there, the pet is in a lot of discomfort, we have to start atropine or e-collar, all those things. But it won't give you a proper result until unless you debride these ulcers. So CTA debridement is nothing but you take a proparacaine eye drop, desensitize the eye, and with a normal cotton CT is nothing but a cotton tip applicator, also known as earbuds. So we can just use the earbuds also. So just desensitize the cornea with the proparacaine, and then after that, try to scrub it or scrape the loose epitheliums from that. So what happens is sometime when I do it, the ulcer will be, the presenting ulcer will be around 3 mm or 4 mm. But when we start debriding and all, we end up covering most of the cornea also, because we'll see like a lot of the epithelium starts coming off with the debridement. So that is normal. Don't panic or don't worry about that. It is just like we end up making them bigger, but we have to remove that dead epithelium from that. Otherwise, it's not going to heal. And usually with the CTA debridement, there is a 50% success rate. So there will be still 50% cases which are not going to get better with just CTA debridement. And if it is not getting better, then we have to go for a diamond burr debridement or grid keratotomy. So grid keratotomy is something which we can do at all the clinics. It doesn't require very hi-fi machinery or something. So it just requires proparacaine eye drop, mild sedation if your pet is not very cooperative, and 25 gauge or 26 gauge needle. So in this nothing, we have to just debride the ulcer first, take out all the loose epithelium and then scrape the cornea or make grids over the cornea so that it acts as a bed for the epithelium cell to get attached to the stroma. And diamond burr debridement also we can do. It is a nothing but scraping off with the diamond burr. Usually these two have 80% success rate. Personally, I don't have diamond burr right now. So usually I do CTA debridement along with grid keratotomy if my case is not getting better with CTA alone. And followed by, you can use bandage contact lens, but the affordability and usability of contact lens in dogs is question mark. If your dog is very much cooperative and all, you can very well use it. If the dog is not cooperative, it's very hyper and all, there is no point in using such lenses. And of course, you have to give broad spectrum antibiotics, atropine. Atropine, if any ulcer, it is very painful and all, you can go for one drop twice or once daily for 3 days. And e-collar. So once you do a CTA, I do a CTA debridement. I usually call them after 1 week, and ideally you can even recheck after 2 to 3 weeks. You have to educate the client that if for two after the debridement or such procedures, the pet will be in discomfort for a couple of days, like 2 3 days. It will be having more blinking or it will be more pain, but after that it will start settling down. And if you feel like the pet is not showing any sign of recovery and all, it is still it is an immense pain and there is no improvement and all, then we might require another sitting for the same procedure. So in this is nothing but a CTA debridement. So it is first we desensitize the eye with the proparacaine eye drops and then take out the loose epithelial lips with the help of the earbud. And in grid keratotomy, I hope you'll be able to visualize that there are some scratches made. So usually we make the grids on the stroma or the exposed part where the ulcer is, and with that it just creates the bed for the epithelium to attach on the cornea. And next one is the diamond burr debridement. In diamond burr debridement, the pet should be sedated ideally, because if they move a little and all, and then it can just destroy the whole procedure. So sometimes what happens is, it's like I would like to tell you that sometimes there'll be a lot of granulation tissue in case of like long-standing scats or indolent ulcers. So if granulation tissue is there and you have the epithelial lip also, just try to debride. Sometimes your cornea might bleed a little, but that is normal. That is bound to happen because when you are debriding, there will be little ooze on the granulation tissue. And usually avoid doing a grid keratotomy on those when there is a lot of granulation tissue, because you'll end up like having uncontrolled bleeding in some unfortunate cases. So next is desmetocele. So it is one of the deepest corneal ulcers. So whenever you are getting any lesion on the cornea where there is a like thin transparent membrane in the center, and followed by there'll be a like ridge, followed by a thick ridge, then just like accept that this is a desmetocele, their deepest possible ulcer, and it is a trouble. So usually these ulcers, there's a loss of epithelium as well as full stromal thickness. So you will end up with a very thin desmet membrane and endothelium over that part. So this ulcer is very dangerous, such that that little prick or little push to the cornea and it might end up getting perforated. So in this kind of ulcers, please assess the size, what is the size of the ulcer, location, and whether there is a presence of blood vessels and all, because this is also one of the ulcers where you have to think beyond the eye drops. or the e-collar if it is not getting healed, or depending on what is the size, location, or the vessel. So the treatment, it depends on the state of infection. If I'm seeing that there is a like lot of infection around the edges and all, and there is like lot of whitish or milky discharge around the edges, I have to be very careful, and I should be ready. I should explain the owner for the medical as well as the surgical treatment options in such cases. So how do I decide whether this ulcer will heal with only the medical treatment or we need a surgery? Is first thing is I will always see the presence of blood vessels near the lesion. If there are blood vessels near the ulcerated site, that means it will heal sooner or later, because sooner or later blood vessels are going to come at the site and they will try to cover up or provide the healing material for that ulcer. But if that ulcer is not getting the blood vessels in 5 to 7 days also, I would rather think of like scheduling a surgery in such case. And second thing is if the desmetocele we are getting is it is near to the limbal area, the area where sclera and cornea joins, it is near to that, then I would rather wait for the surgery, because near that limbal area means this like conjunctiva is going to provide the blood vessels over there, and this ulcer will eventually heal. If we take care of other things properly, it will heal. And when we do a fluorescent dye in such cases, so this thin membrane in the center doesn't get strained, because remember I said that fluorescent dye has only affinity towards the cornea. It doesn't have any affinity on the descemet membrane. So you'll see that edges will be having the dye uptake, but not the center. Center will be very thin, transparent layer. In such cases, if my pet is very much hyper and all, so rather than taking a risk, please go for a mild sedatives. Also, you can use gabapentin or trazodone in such cases, so the pet becomes little sleepy or little calmer, so that it doesn't worsen the situation. So yeah, so in this there's an ulcer which is just at the limbal site. So in this case, I did not have to go for the surgery, as it healed very well in a span of like 10 to 14 days. There was of course a scarring, but that doesn't matter. If we are going for a surgery also, that will also end up in the scarring. Uh, Usually in the second diagram, we can see, one second. Yeah. So in the second diagram, we can see that there is a very thin membrane in the site or the area where there is no dye uptake, but in the surrounding, there is a edge where it is greenish. So that's what is desmetocele looks like with the dye test. So in the center, there won't be any dye retention, but in the edges, it'll dye uptake will be there. And now red means healing. So you're seeing so many vessels over there. So in this case, I would not like to unnecessarily go for a surgery, because I know eventually these blood vessels are gonna come here. They will provide the healing material and this will heal. If the same thing in the center, there's a big desmetocele and like we are not seeing any blood vasculature over there, even waiting for 4 to 5 days also, then I would like to plan the surgery for such a case. So if we are seeing the blood vessels around the ulcer, that means we are on the safer side. Whether it's a superficial ulcer, it's a deep ulcer, or it's a scad or indolent ulcer. Next is keratomalacia or melting ulcer. These are the most trickiest ulcers to heal, and these are one of the ocular emergencies. If they are not taken care properly, sometime we have cases where cornea just vanishes up in the span of 24 hours also. So how these ulcers will look? These ulcers will be usually cornea will be very squishy, milky white in color as if it is melting. And it will be basically softening of the cornea will be there. So what happens in this is degeneration and liquefaction of the corneal stroma happens because of the increased enzymatic activities. So now here the role or the knowledge of proteases comes to existence, that in this sort of ulcer there is a lot of enzymatic activity that is leading to the liquefaction of this collagen. So this collagen, as if it is flowing down. So this is like a melting ulcer. It is a corneal emergency. Same thing we have to transfer to the or communicate to the owner also. So in this ulcer, what happens is basically there are most likely there'll be infection also, and even bacteria produces its own proteolytic enzymes. There'll be proteolytic enzymes produced with the keratocytes or inflammatory cells or the corneal healing cells, all those things. So there'll be overwhelming activity of the enzymes. So these enzymes basically lyse the collagen, and this looks like a melting ulcer or melting cornea rather. Most of the common bacteria involved in this sort of ulcers are Pseudomonas, and we get beta hemolytic streptococcus infection. So again, this sort of ulcer is also not going to heal with a normal antibiotic drop or normal whatsoever medications we give. So it requires, in these ulcers we can use serum or plasma. So when we are using serum or plasma, there are sometimes we have very like small breeds where we cannot make enough plasma or serum. We cannot like retain enough blood. So because of that, it becomes a challenge for them to provide with the serum every drops. And if we are using serum drops, we have to use it one drop every 2 hours, at least for 48 to 72 hours. And even if serum from the same dog, autologous serum is not possible, we can use even the serum from any other dog also. And in fact, many people don't know, but even equine serum is really good. But as far as cats are concerned, cats, there should be autologous serum only. You cannot use any donor serum for the cats. Second eye drop which we can use is EDTA eye drops. Usually 1 to 3% EDTA eye drops we can just use. We can just uh, fortify them with our own only, because unfortunately right now we are not having any commercial preparation of the EDTA eye drops. Same as with the N-acetylcysteine. Usually, I would like to go for the oral tetracyclines also, like doxycycline in such cases, because doxycycline is not providing only antibiotic umbrella for this, but some studies show that they have a role as a immunomodulator also, and to some extent they help in controlling this enzymatic activity also. So these ulcers are complicated ulcers. This has to be taken care properly. If I feel like it, in spite of doing all the treatments and all, still I'm not getting the response which I wanted, so better to go for a cytology. Cytology is nothing but the microbrush. We can just scrape off the some cornea and just test it for like what is the cytology, like what kind of bacteria, whether it's cocci or rods are present over there. And we can go for culture and sensitivity testing also, but practically saying I don't go for a ABST testing, because obviously it takes like much more time for the result to come, and till the time I won't like to wait for such an ulcer to get better of its own, because this is an emergency. We have to do something. I cannot just sit and wait for the report to come and then start the treatment. So treatment involves antiproteases. Antiproteases like EDTA or N-acetylcysteine drops, serum like equine serum can be used, or autologous serum also can be used. So right now we have a question also, like eye drop indicate contraindicated for corneal ulcers. So please share your responses and we will have the answers at the end of the session. Okay, so as far as treatment of such complicated ulcers is concerned, so with the cytology, we will get a good idea that what kind of bacteria are involved. If I'm getting a cocci or a or a rods over it, if there are more cocci as compared to the rods, I would like to go for the fluoroquinolones like ciprofloxacin, ofloxacin, and all that. Also, in these kind of ulcers, we have to go for the eye drop like every 2 hours for next 24 to 48 hours. You have to communicate to the owner that in the night also they have to put the eye drops every 2 hours. There is no leniency in that. So that has to be communicated well. And we can, and next thing is we can don't overuse the antibiotic also. We can use antibiotic like for maximum in such a frequency like every 2 hours. We can use only for max 2 days, because if we continue using at such a frequency for more than 2 days, even antibiotics can turn epitheliotoxic. They will also start hindering your corneal healing. And if the my patient was already on fluoroquinolones and still it is not getting better, I'm still at the same page and all, I will go for the fortified cefazolin and tobramycin eye drop. That is also every 2 hours for next 24 to 48 hours. Usually cefazolin is a normal like we can make from the injectable form only in the concentration of 3.3%, and we can store that in the refrigerator for next 10 days. Then comes antiproteases. Antiproteases main thing is the autologous serum. So with this, we know that serum is not required for all the ulcers, but it is required for kind of melting ulcers or complicated ulcers where we are not seeing the healing as we wanted or we expected. So autologous serum also can be used quarter 2 hours. Like it is also every 2 hours for 24 to 48 hours. And when you are putting multiple eye drops, please remember telling the owner that there should be at least 5 minutes gap. If they are putting everything together at a once, it won't be of any use because 70 to 80% of the eye drop is gonna eventually gonna come out. And even melting, if you feel melting is very fast, we can use EDTA or N-acetylcysteine drops also. I would like to put these patients on oral doxycycline. Sometime even if I feel that there is a lot of discomfort, pain or hyperemia around the eye, there is a lot of redness, then I usually go for the oral NSAIDs or steroids also. And since there is a lot of pain in these eyes, we can use atropine eye drops twice daily for next 2 to 3 days. And of course, e-collar. I would like to recheck these ulcers 24 hours. Like then, if it is getting better, I will call them after 2 to 3 days, then after 5 to 7 days. So next is this is not very common. We don't get calcium deposits or corneal deposits in most of the cases. Usually it is more prominent in the aged dogs. When I'm getting a case where the dog is 10 to 13 years old or it is having some deposits and all, if it is not ulcerated also, I will always tell the clients that this can ulcerate in the future, so they have to be little careful. Usually sometimes we see a lot of vascularization on those areas, or a lot of sometime it makes them prone for the ulceration also. So if we are getting an ulcer which is having deposits also like calcium deposits, we can use calcium binders like 1 to 3% EDTA. The more stronger is the EDTA, the more effective it is. But we don't usually go beyond 3% because after that it becomes really harsh and it starts stinging. So it will be really irritating for them to have EDTA. And we can use EDTA drops every 4 to 6 hours for a few days. If it is a milder one, like a 1% EDTA drop, it won't be that effective. So usually I would always try to keep it on the little 3% concentration. And it always works for the superficial deposits if the deposits are long standing and those are very deep, like extending to the stroma. So usually such drops don't work that well. But sometimes some owners are like they want to get rid of the ulcer or get rid of that deposit. So in such cases, we can do the diamond burr debridement followed by a contact lens. But please tell them that there'll be 50% chance that it will come back again. And usually, as it is in an old dog, so rather than putting the old dog under anesthesia and doing a diamond burr debridement, and that also has a chance of 50% recurrence. So I won't recommend doing a debridement for such thing. If it is like there's no ulcer, let them be just like that only. And if there is a ulcer on such a part and all, we can use broad spectrum antibiotic every 6 hours. And I would like to recheck these cases in 1 to 2 weeks. So next is, if ulcer is not managed properly and all, it will end up perforating. So sometime even at the presentation itself, we have perforations where the all corneal layers are gone, and there'll be protrusion of the iris outside, or there'll be leakage of aqueous humor. So whenever we are getting perforations, please assess the size, whether it is leaking aqueous humor, your anterior chamber is formed or not, there is iris prolapse or not. Usually what happens is, when the perforation is very, very small, there'll be a leakage of aqueous humor from the side. And when aqueous humor comes in contact with the air, it forms a fibrin plug. So that fibrin plug usually like will give us a appearance that there is no perforation. So in such cases, we can use a Seidels test. So it is very simple test that can be done with the same fluorescent dye. So that can be done to find out or differentiate whether there is aqueous humor leakage or not. So in this picture, basically nothing is there, but there's a protrusion of the iris. So it is an old case. So it has already protruded and it is already settled. So in this, anterior chamber was fully vanished and lot of iris was protruding, like projecting out from the eye. Though the pet was pretty comfortable, initially it had discomfort, but over a period of time it settled down. And whether to go for a surgery or go for a medical management or just leave them like that, it depends on their reflexes also. So I always see the pupil margins in such cases. If pupil margin is visible, I could see the pupil margin, or there are reflexes in the eye, or even sometime PLR is not possible to see in such eyes, so I'll go for a consensual PLR. I'll put the light in the affected eye and see the PLR on the other side. That will also give us the idea whether how much retina is working. If we get a positive PLR in such eye and all, then it is worth taking a chance to save the vision and go for a surgery. But if I know that it is pretty long standing case, the anterior chamber is fully gone and there is like fibrosis over there, there is no point in going for surgery also. That will be unnecessary discomfort for the pet. And next is the corneal vasculature. So we have to assess whether vessels are present over there. So now, in case of perforations, whether we have to go for a surgery or we have to do medical management. Sometimes there's a constraint that after just taking a name of surgery itself, owner will be scared to hell and they won't go for. But usually, how I assess normally whether it's surgery is required or not is, if pet is not visual, it is a delayed case, then we can go for a medical management. And if we feel like pet is having lot of discomfort, like lot of pain in that eye, and it is like here and there getting ulcerated or bleeding, then I would rather suggest them going for enucleation rather than going for a like corrective surgery. But yes, if it is a fresh case, it is the pet is visual, and then there is a it the surgery is worth, but we have to in prior itself tell the recovery period that it will take some time. It is not like any other surgery done on any other body part, and there will be, you should always expect some or somewhat scarring at the site. So in this case, this is also a corneal perforation only. So if we see at the center, there's this very small spot where the cornea is perforated. Actually, this was a desmetocele. This was full desmetocele, which was not managed properly or timely, and that led to a perforation in the center of the desmet membrane. So this plug is nothing, but this is a aqueous plug only. So there is a aqueous humor leakage from that side. यहाँ पे थोड़ा है this aqueous humor leakage which has formed the plug, and now that is maintaining the eye for a time being. And how Seidel test appear is, it is nothing but we put a fluorescent stain on the cornea and we wait for some time, and there will be a leakage of aqueous humor which will give the stream-like appearance. So if we get like there is something coming out like a fountain from inside, So that means there is a perforation and there's a breach in the aqueous anterior chamber and your cornea is perforated. So when you ask me in this case, I would rather wait rather than jumping for a surgery, because I can see that this is infected. So I will, rather than jumping to any surgery or something like that, I will do first medical management. Like I will do a intensive antibiotic treatment also. Because we can see some yellowish white plug over there. That is nothing but it's a basically because of the infiltration of WBCs at the site, but body has started making its own plug. So usually if everything goes well, we take care of the infection properly and all, there'll be a scar formation over here on this area as the time passes by. But still I will assess this ulcer every 3 days, because at any point of time I feel like this is not helping, then I will go for a surgery in such cases. So, other than that, apart from surgery or medical management, obviously we have to go for the antibiotic eye drops. If there is a lot of pain, we can go for atropine, but use of atropine is question mark. Don't blindly go for a atropine in such cases, because what happens is sometime at the perforated part, iris will start attaching over there to make a plug, so that it doesn't ooze out the aqueous humor, or it is forming a plug so that other eye parts are not bulging out further. So in such cases, what atropine will do, it will dilate the eye. So that attachment of the iris, which was preventing the further perforation, will be destroyed, and we will end up having bigger protrusion or prolapse rather than what we had earlier. So in such cases, I would rather not go for atropine. In general case, if you have any doubt and you are not sure, you can avoid atropine. Serum use is also question mark in this, because if there is no melting or there is no much infection and all, serum won't play much roles in this kind of ulcer. And please don't use any ointment in such sort of ulcers, especially in cats, because cats blindly, most commonly, we go for a chloramphenicol applicaps. Usually, what happens is the preservatives or carriers in such ointments are not very safe to be used intraocularly. So when we are suspecting perforation, obviously whatever we are going to put on the eye, it is going to reach the anterior chamber also. So in such conditions, please avoid use of any eye ointments. Obviously, we have to go for the oral antibiotics. I will go for pain medications also, as it will be really, really painful. And most importantly, sedatives as well, because these pets have to stay very calm. If they are very hyper and all, no matter what you do, your ulcer will keep on leaking and here and there, and it will hinder your treatment. So I will, if it is very big perforation and all, straight away and it's a fresh case, I would take them for surgery. Or otherwise, if I feel that it will get better with the medical management also, then I will recheck after 3 days. Usually you have to tell the owner in advance that there'll be a scarring at the place, and it will take weeks to month to heal. So what do we have to look for the healing, whether like it's healing or not? How do we know that? First and foremost thing is whether we are getting a seal over there or not. If we are getting an aqueous plug over there, or there's a fibrin tissue which slowly starts covering up that defect, then means we are on a good side and we can manage it further. Second thing is obviously vascularization. If you see here, there are very small blood vessels which have started coming over. So usually this is a early phase. It is just like a week old ulcer. So if we are seeing small blood vessels have started coming in. As the time passes by, they will start moving towards this side. So if they are moving toward this side, slowly this will start healing. And natural healing forms a smaller scar than the surgical scar. So if I'm seeing these blood vessels and there is a seal over here, so I am little comfortable that this will heal. This might not require surgery as an emergency procedure. Like body has started or initiated its own healing process, so this will heal. And Last but not the least, your pet will be comfortable. There won't be as much as blinking. Sometimes some pets will have that much pain that they won't eat also, or they won't open the eye. So if you are seeing a relief in such signs and all, then we are on the safer side. We need not rush for the emergency in such cases. And when to go for a enucleation? If the pet I am presented with is in lot of discomfort and almost half of the iris is prolapsed out, or pet is non-visual, if there is bleeding in the anterior chamber and lot of iris is lost in the prolapsed part, and health status of patient is not good enough that it can withstand so many medications or something, or even my medical therapy fails, then I would go for enucleation. And if pet is visual and it is having some, or the like iris can be saved, I'm seeing the pupil margins, like I can see here, I can see few pupil margin like hai yahan pe. So in such case I will go for a surgery. But when there is nothing, most of the iris is outside only, then there is no point in correcting that eye, because that is not gonna help the pet the way we wanted. So next is surgical options. What are the surgical options we are having apart from enucleation? We can go for conjunctival graft, corneo-conjunctival transposition graft, or corneal sliding graft also it's called as. Amniotic grafts, third eyelid flaps, or tarsorrhaphy. So usually my choice of treatment is CCT, and when CCT is not possible, nearby cornea is too much damaged or something, I would go for the second conjunctival graft. And usually, if my perforation is very big, that time I won't like to go for the amniotic grafts because they are not very stable. But if my perforation is just 1 mm or 2 mm and all, and I have a healthy cornea on the sidewise, then I can think of doing an amniotic graft. And usually, personally, I don't like third eyelid flaps or tarsorrhaphy because my simple funda is like I cannot see what is happening with the eye. So that's why in such cases, but if we are at the field level or something where we such surgery or procedures are not possible, and all that time we can use third eyelid flaps or tarsorrhaphy. Sometimes they are very, very helpful. So this is basically human amnion chorion allograft, which can be used as a grafting material on the affected cornea. So treatment principles of corneal ulcers, if we see, every ulcer requires certain things, like E-collar is mandatory for all the ulcers. We have to provide broad spectrum antibiotic coverage for the ulcers, and we have to address the underlying cause, see if any eyelid abnormality is there, or there is entropy on dry eye, all those things. We have to correct them. Then only we can long-termly manage those ulcers. Obviously, prevent the infections by using broad spectrum antibiotics and all. Prom- promote the healing. If we have the indolent ulcer, debridement is required, or if we have melting ulcers, we can use serum. Especially avoid corticosteroids, topical corticosteroids on the cornea when we are suspecting ulceration. Steroids have no role in corneal ulcer healing. Ulta, this will go for like this will worsen the situation. Usually what steroids do is they increase the collagenollytic activity, they inhibit the collagen perforation. So because of that, if the ulcer had to heal in like 3 days or 5 days and all, it will further deteriorate, it will heal in another 2 weeks. So there is no point in using corticosteroids, and even NSAIDs are contraindicated topically on the ulcerated eyes. If we are not sure whether it is a ulcer or it is another thing and all, don't blindly go for using steroids, because it is our like ready to use over the counter medication that we are going to give moxidexa. If the pet is having more blinking, just directly give moxidexa, but please don't do that. Second thing is, whenever, like when it's coming to the broad spectrum antibiotics and all, most of the time we blindly go for moxifloxacin, and that is the most readily available veterinary formulation present this date. Usually, gatifloxacin and moxifloxacin are the most commonly used antibiotics, but ideal is better to go for a broad spectrum antibiotic and rather than just going to straight away fluoroquinolones, which are very higher antibiotics and should be used in like higher infected ulcers. So don't make your pet's eyes resistant to such antibiotic, because when they are in really in a need, we won't have that time any antibiotic left. And last is protecting cornea. Protecting cornea, most of the common is like using e-collar. Second is bandage contact lens, but that are not very much applicable when it comes to the like pet sector. And protecting cornea with the help of graft also we can go. So this was a pug 7-month old which was presented with the corneal perforation. So its anterior chamber, we can see it's fully collapsed and there's a huge dent on the center. So it was a fresh case, so we took him for a surgery ASAP. And in this case, since the cornea was like this, cornea was there was a lot of edema and was not very healthy and all, I went for a conjunctival graft. So this is how it looked like after surgery. So we can see that already there is a filling of anterior chamber. So this we can see like little iris part also, there is no bulge and all, anterior chamber is forming, which is a good sign. And usually I keep the flap intact for at least 10 to 14 days. After that, when I'm sure that this is working and this is healing properly and all, then after 14 days, I cut the stump. So this is how it looks. Over a period of time, this granulation tissue will go off, like it will fade up, but there will always be a scar. And another problem with pugs are that they have that redundant hair folds, nasal folds, medial entropion and all. So there sometime what happens is in pugs there'll be a lot of pigmentation over that area. So right now, fresh case, it is looking like a pinkish area, but as the time passes by, there'll be non-uniform black pigment over here. But still, the pet is visual, so our aim is it's worth doing surgery in such case. So this was another case which had a like trauma, something sharp object got stuck with a something sharp object and it came like bleeding to us. And the pet was literally like bleeding from the eye. It was not allowing even to touch at all. So we decided to go for a immediate surgery. And this is all blood clot and a prolapsed iris. Even here also it is nicely visible, and we can see that anterior chamber is fully collapsed. There is hardly nothing in between the cornea and iris. So in nothing, first step is like we just take out this clot and debride the edges. Debridement of the edges is very, very important because I don't want any unhealthy tissue at that site. Obviously, there'll be bleeding or sometimes there'll be lot of bleeding or like lot of discomfort, but it is like a challenge, but it is challenge worth taken. So in this, what we planned is we just took a flap we just undermined the adjacent cornea along with conjunctiva, and then this corneal defect was replaced by a adjacent cornea itself. So this is a conjunctival part and this is a corneal flap. This is the undermined adjacent cornea. So we covered up this area with perforated area with the cornea itself, and that's how it looks. So this part, the front part is the cornea and this is conjunctiva. And usually I use like 8-0 over there, even 10-0 also can be used, no problem. So this was day 5, this was day 10, and on day 21 it was like a beautiful eye. So this scar will persist slowly, it can little fade away, but that is not affecting vision and pet is visual. So the purpose of surgery is served. So this is again one CCT for the iris prolapse. In this case, this was little delayed case, but in this I could see the pupil margins. It's not very much like very nicely visible in the photo, but I could see little pupil margin. So I was like, and it was very young pet, so it was worth taking a shot. So nothing, first we prepared the surgical site aseptically. I removed the prolapsed iris. This is how it looked after removing the iris, though there'll be a little bleeding and all, but by topical styptics like adrenaline, we can arrest. And further, we took a like corneal sliding graft only, like cornea from the adjacent along with the conjunctiva to cover the defect. So it was post-operative. And then this is a post-operative day 21. So there's a healing, and this is the graft. Obviously, it will end up having a scar, but the eye is perfectly visual and pet is not having discomfort. So when it comes to cats are very good client for corneal healing. Though cats cornea heals very well with a minimal scarring. And for cats, usually for any corneal ulcer, we can go for a broad spectrum antibiotic. I would like to go for tobramycin or chloramphenicol for cats, as we see many allergic reactions with the neomycin in cats, and I usually don't prefer using fluoroquinolones because of the retinal toxicity in cats. So if I have to use, I will use max for 5 days. And but always I go for chloramphenicol or tobramycin in cats. Terramycin is nothing but a OTC eye drop, so it's not available currently in India. If we have to use, we can use tobramycin or we can use 45 OTC eye drops. And then most of the cats are prone for herpes virus corneal ulcers. So in that we can use antivirals. If cats have perforations, they heal very well with the medical management itself. So far, I have done only one case where I had to go for a surgery because cat was very relentless. It always used to go and scratch and end up coming with the same perforated ulcers. In that, we had to do a flap, but otherwise, all of other cats till now have healed without any surgery. And usually, if we get a lot of like a big iris prolapse in the cat, like it is like protruding, a lot of the iris is protruding. Sometime, rarely, such cats in the older age, they can go for sarcomas in that affected eye. And cats respond great to grafts. So cat's cornea heals very well. It is like it has a beautiful capacity to regenerate and heal. So in cats, mostly we get herpes virus ulcer only. That is mostly in the kittens. And usually we see dendritic ulcers. These are nothing but a branching like ulcers. Frankly speaking, I have seen this proper ulcers only in 1 or 2 cases so far. Not always these ulcers will be presented in such a pathognomonic presentation. Usually what happens is this herpes virus replicates in the corneal epithelium, and this creates this branching pattern which is pathognomonic for the herpes virus for the cats. And the treatment will be topical antibiotics. I usually go for the chloramphenicol applicaps for such cases. Along with, if it is not getting better, I go for a oral famciclovir at the rate of 90 mg per kg BID for 2 to 3 weeks. If the cat is getting better also, sometimes I tell the owner that if I feel that cat's immunity is not good, I go for like more than 2 weeks or like 2 weeks after the after recovery also. And if we have to use topical antivirals, it will be 0.5% Cidofovir or Ganciclovir 0.15%. So this is all human formulations only. Uh, Other than tobramycin, I don't think we have any vet special formulations. So we can easily get it, but in the human side. So usually if any corneal ulcer in cat is persisting for long time, so sometime what happens is the corneal tissue goes for necrosis, and this necrosis is called as sequestrum. So in this case, this cat had inward eyelids. So always this hair kept on like irritating this area. So we can say that there's a deep vascularization along with this brown discoloration of the cornea. So this brown discoloration is nothing but the affected part is slowly dying. So this is a necrosis of the epithelium which is giving a brownish appearance. So we can see exactly at the places where this eyelid margin is inverted, there only we see the ulcer. We see like upper part is quite clear. this margin is quite clear. Same was with this eye also, like such a big ulcer. So until and in this case, until unless we take care of entropion, no matter what you do, what higher antibiotics or what exotic eye drops you use, it's not going to get better. In this case, we need not do any, I didn't do anything for the cornea except going for the antibiotic drop. We just went for the correction of entropion and cat healed beautifully in 14 days. So this is a particular case of corneal sequestrum. So it is very long standing. So that's why it has almost become blackish. So if ideal treatment for corneal sequestrum is surgery only, you cannot treat this with the eye drops. So nothing, we have to just scrape off or do a superficial keratectomy. We have to take out the affected corneal layers. And if the defect is too big, we just cover it with a flap. So here, this was the defect. So we did a superficial keratectomy over here. So in the end, it is just like a fresh ulcer over the eye. So just to provide it another tectonic support, we did a conjunctival graft over the eye. So, and another thing is if these corneal sequestrums are not taken care properly or timely, these become deeper to the extent that sometimes it reaches the endothelium, and at that place we cannot do anything. Even surgery also won't help much in such cases. And sometimes they start becoming bigger in size. So it is better to treat them early as possible. Whenever you find them, just treat. So this was day 10 and this was day 30. So cat didn't have any, and in corneal sequestrum also cats will show all signs of the corneal ulcers, like there'll be discomfort, there'll be pain, squinting, lot of watery discharge, all those things. So after surgery, cat was doing pretty well. So next is the latest advances. What is new in this field is corneal cross-linking. Corneal cross-linking is nothing but we are basically helping the collagen to make bonds, like basically the stroma. We are potentiating the stromal healing. So this can be used in the septic ulcers, melting ulcers, even bullous keratopathy, keratoconus, all those things. So usually we try to like make new bonds in the collagen or make the collagen fiber mesh fastly. So in this, there'll be stabilization of the cornea as well as there'll be elimination of microbes. So nothing but we expose the eye to 0.1% riboflavin for 30 minutes, followed by exposure to that particular eye in the UV light for next 30 minutes. So UV light used in this is 370 nanometer. And of course, we'll be doing the debridement of the ulcer first and then removing the dead tissue, then only riboflavin, then only UV light. So it appears something like this. And then later on, if you feel that there was an infected ulcer and all, we can just do a subconjunctival antibiotic shot also. Next is Stromaze. It is the new eye drop which is having, and this is nothing but N-acetylcysteine, so it can be used in the melting ulcers. This is to be used one drop 3 to 4 times a day. Next is hyaluronans. So this is nothing but a complex hyaluronic acid. Hyaluronic acids help in collagen formation. Basically, it promotes cell migration, additions, or proliferation of the collagen in the stroma. So it helps in healing the ulcer faster. So this product is right now not available in India, but this is like a hyaluronic acid complex which helps in promoting the corneal healing or recover the stromal defects fastly. Then matrix therapy agent, this is quite new. This is nothing but an extracellular matrix substitute. It is something related to stroma. It is extracellular matrix is something which helps in making the new, like covering up the stromal defects. So this usually creates supportive environment for for the collagen to form or proliferation of the collagen and helps in corneal healing. So we have to use this 1 to 2 drops, and this is to something new that this has to be used only twice or thrice a week. and we can formulate the usage or how much we have to use or till how long we have to use as per the improvement. So next question comes, when to refer. See, there is no shame in referring a patient. Referral at a particular or a correct time is also a form of treatment. So if it is not getting better, please refer. If any ulcer which you are treating and it is not improving in 7 days, it's better to refer. In case of indolent ulcers which are not getting better and they are creating a ruckus or a headache and all, it is better to refer to a specialist. And irrespective of you doing all the treatment possible in your knowledge and all, still it is not helping the pet and it is worsening the case, please do refer timely. And in case of reconstructions, when pet is requiring the emergency reconstruction which could save the vision and all, it is always better to refer. So take home points is, from this presentation I would like all of you to know that uncomplicated ulcers heal within a week. Antibiotics help in preventing the secondary infections, but they don't heal the ulcers. And please don't straight away jump for the moxifloxacin or fluoroquinolones in the normal ulcers also, because they end up spreading the resistance. And there is one more fact that ciprofloxacin and ofloxacin penetrate very well to the anterior chamber. But same thing, if we see the spectrum of moxifloxacin has comparatively narrow spectrum of spectrum of activity compared to cipro and ofloxacin usually, and it doesn't penetrate inside of the eye very well as compared to of cipro. So in this case, moxifloxacin is a higher antibiotic, but it is not the best. So if we can manage any case with the normal antibiotics like neopolybac or chloramphenicol or tobramycin, then please go for such antibiotics first. Keep fluoroquinolones at the end. Don't straight away write moxi for all the cases. Evaluate the ulcers like their size, location, infiltrate, vascularization, all those things, and then decide the treatment plan. It is not always like we are going to give high Getty or high cool and ulcer is going to get better. It is beyond that. And cornea itself, once you examine, it will tell you what to use and what to not. And never ever use topical NSAIDs and steroids on the corneal ulcers. It is going to make your ulcer bad. And recheck is must. It's not that once you give the treatment, pet is fine in 3 days, and you just leave it over there. Please do a recheck till the time your dye is coming negative, or you are sure that ulcer is healed and pet is not having any erosion or anything left over there. Refer timely. E-collar is must. And ophthal is beyond high Getty and high cool. So it is not always we are just blindly prescribing the antibiotic and that ulcer is going to heal. All ulcers don't require serum. Which ulcer requires, I hope you will be in a better understanding now that where to use what. But basic things like go with the basic antibiotics, put the e-collar, refer timely, understand first what is happening with the eye. So with this, I would like to finish my presentation, and now the topic is open for discussion.
So thank you, Dr. Yamini. So there are some questions.
Yes, sir.
So the first question is why eye drops containing steroids should not be used in corneal ulcers.
Yeah. So, sir, basically steroids inhibit epithelial regeneration. And cornea, when we are using steroids topically and all, it is inhibiting the epithelial regeneration, means it is going to delay the ulcer healing also. Usually it will increase the activity of collagenase also. In many studies, they have found that collagenase enzyme activity will increase further. It will go for the collagenylysis. One thing is trauma requires collagen. So if collagen is not formed, second thing, epithelium is not forming. So obviously your ulcer healing will be delayed. So we don't want, and if you have an infected ulcers, obviously it will increase the risk of bacterial infection also. So because of these three reasons, don't use steroids topically. If pet is having lot of discomfort or lot of pain or something like that, if you want orally, you can do it, but not topically.
So the second question is, can we give steroids systemically in case of corneal ulcers?
See, if there is a lot of pain and discomfort and all which is not being managed with the eye drops, like if you feel there is lot of pain and discomfort, pet is having lot of discomfort, say it is blinking eye a lot and all those things, we can use atropine. Atropine once or twice daily for 3 days. Irrespective of that, you are not seeing much improvement or eye is very red and all those things, that time we can use, but not mandatory. It is not a part of like oral regime that we have to use steroids, otherwise it won't heal. Because whether you are using or not using, it is going to heal. So it is optional.
Okay. The
Yes.
third question is there any role of giving vitamin A tablets in corneal ulcer patients?
Sir, as such, if the food is good, I won't find any much role in that. If you are giving it just as an antioxidant or say antioxidant or just a supplement and all, I won't mind it. But there is no as such like direct relation in the corneal healing or something like that. So it is like it depends on you. It is not mandatory. Like I don't so far I have never ever used vitamin A.
No.
Yeah.
So this it is out of this one. Ma'am, can you please explain about proptosis in brachycephalic braids like Shih Tzus and detailed treatment options?
Okay. So basically, proptosis is nothing but the bulging out of the
Socket.
eyeball.
Yeah.
So it is like if we are, it is obviously it is a surgical management only. We cannot wait for it to go inside of its own. So nothing, but it's like when a case come to you, first thing is don't panic. Owner will already be panicked, so and pet will be panicked, so you don't panic. Second thing is like please put something saline. The eye when eyeball is out, it will be fully dried up. So at least lubricate it and put some like try to clean it. Put some like gauze piece over it and some lubricant, say chloramphenicol ointment or another lubricant or whatsoever, and try to reduce the swelling at the site. Keep the pet like sedate a pet a little or give him a painkiller so that it calms down. Second thing, put the e-collar and then comes to the treatment. So meanwhile, it is like we have to go for either enucleation or we have to go for a temporary tarsorrhaphy. Most of the time, what personally I do is like if the eyeball is like inside the socket and there is no muscle tear, like if my muscles are intact, there is no muscle tears, then I will always try to save the eyeball. So I will go for a temporary tarsorrhaphy in those cases. But there are some cases where it is very bad that only one eye muscle will be there and all other like four eye muscles are torn out. In such cases, there is no point in going for placing the eyeball back, because if you place also, once you remove the suture, it's gonna come out. So if muscle tear is not there, your cornea is healthy and all other things are fine, then we can plan for temporary tarsorrhaphy. Same thing if there is a corneal rupture or two or more muscles are ruptured such that it is like just hanging out with the optic nerve also. As such, you can see the optic nerve also. In such case, there is no use of doing like temporary tarsorrhaphy. So for temporary tarsorrhaphy, it is like, so do I have to explain the procedure?
It's
Yes,
better
ma'am.
to explain the procedure.
So next question is why NSAIDs is contraindicated in corneal ulcers?
The same is with the NSAIDs also.
Yeah,
Like
yeah.
they also inhibit the like epithelial regeneration. And the only thing with the steroid is extra is that it increases the risk of bacterial infection. And in case of feline herpes virus ulcers, no, if you are using steroids, like it will exacerbate that infection, that herpes virus infection, or sometime fungal infection, all those things. NSAIDs don't do that, but still they inhibit the epithelial regeneration. So that's why topical NSAIDs are contraindicated.
While going for the corneal conjunctival flaps, instead of suturing using 80 or 10-0 vicryl, is there any glue which can be used?
No, no glue can be used because perforation is something that there'll be always a leakage of this aqueous humor from that side. So until unless you have something like to stick on, there should be in perforation, there won't be anything to stick on. Cornea has lost all its layers. So there won't be anything to stick on. So if there is no base, we cannot use glues. So this has to be only stitched. We have to take sutures only. And in such sites where it is like always have tears and it is always a wet site. It is not a dry area where you can put a glue and just stick it. So it's not gonna help it. It is waste of time. And if, yes, one more thing, when perforation is very small, like it's a pinpoint and all, that time, and it's uncomplicated, that time maybe you can think of. But I will always go for a conventional thing. I'll always opt for suturing. Yeah.
So can we use serratiopeptidase orally in case of the ulcers?
Yes, we can use in some of the cases where I see like lot of swelling on the eye or lot of like conjunctival changes and all and petis and like lot of inflammation. In those cases, I use serratiopeptidase just to take care of the sidewise inflammation and all those things.
Have you tried mixing doxycycline with tacrolimus ointment in case of the KCS dogs prone for corneal ulceration or already ulcerated? Some recent studies says doxycycline has MMP inhibitor and IL-1 synthesis effect.
Yes, doxycycline can be. So far, I have not come across anyone using doxycycline topically. Though in such cases where I feel that there is a melting and all those signs, like if there is a lot of like such enzymatic activity and all, I always go for the oral doxycycline in such cases. Because it has, as I told also, that it has a immunomodulator activity also, not only the antibiotic spectrum, but it helps in like the controlling the activity of proteases. So we can use, and I don't see any use of using like tacrolimus in ulcer cases. Whether in the dry eye cases, yes, we can put the pet on the tacrolimus topically.
Yeah, the next question is, can we use third eyelid flap as a covering of corneal ulcer to promote faster healing?
Yes, in field level, when we cannot go for the CCTs or conjunctival graft and all, it is always advisable that if we cannot do anything and we have to provide some support to the cornea, then we can use third eyelid flaps. And only it is like surgeons to surgeon, there is like always preference for the procedure. So it is my preference that I always want to see what is happening with the eye. So I feel like I'm little impatient in that sense, that I always want to see like whether it's healing or it's healing in a correct matter or correct way. So that's why I keep third eyelid flaps in a situations where I cannot do anything. But if I opt for a surgery or this thing, my first choice will be the normal CCTs or conjunctival grafts. But yes, in the field level, when you cannot do anything, any of these, yes, please, like we can go ahead for the third eyelid flap.
Is it true that some cats are allergic or intolerant to neosporin eye ointment? If yes, what could be the reason?
So usually there was one paper also that cats have like allergic reaction, and in that paper, that study was I think conducted on 61 cats or so. But it was like out of like 50% or 51% of the cats in that study, they said that 51% of the cats developed allergic reaction, like to the eye drop after just 10 minutes only. So that's why like it is little like it has to be used cautiously. So 50% of cats had that, 50% of cats didn't have. But there is no like known cause like why cats do behave different. Sometimes it will be allergic reaction, sometimes it will be stinging or irritation, all those things. But because there are there are like studies which have said that there is allergic reaction. So usually I unnecessarily don't like take a risk in such, because cat clients are always very sensitive. So why to unnecessarily in such cases, if I don't have anything, I go for tobramycin. Yeah.
Thank you, Dr. Yamini.
Yeah.
You have well explained about the common ophthalmic conditions in our day-to-day cases, and you have well explained about the causes behind the location of ulcers, evaluation, the types, and their treatment. So it is very nice presentation. You have given a 75-minute a brief discussion on practical approach to the corneal. So it is very nice, doctor.
So I know it took like little, I took little more time. I'm so sorry for that. But it was like, it is, my only thing is it is just not simple eye drop and one eye drop and we can just create wonders. So it is beyond that. So
Yes,
there are
yes.
a lot of treatments.
Thank you, Dr. Yamini. On behalf of the Andhra Pradesh Pet Practitioners Association, it is a very nice presentation from you, and we are expecting more from you like these presentations. Thank you for your a nice presentation.
Thank you so much, sir, for giving me an opportunity. It's my
Thank you,
pleasure.
Emily, for readily accepting our invitation and giving a nice lecture. So we hope you'll be ready for the next one in a few short time.
Sure, sir. We'll see.
Okay,
Yes,
thank
sir.
you.
And
Thank you for the participants. Thank you for the participants. We'll give you update the next presentation dates. We'll update you in our APPA group. Thank you for your participation.